My name is Michelle MacDonald. I am a clinical dietitian and a certified diabetes educator at National Jewish. So unfortunately, I don't have the opportunity to work here, but it was at National Jewish where I met Dr. Fisher, and he pulled together myself and a few other providers to try and get an interdisciplinary team to help scleroderma patients. So I started seeing scleroderma patients at National Jewish. That was about 6 years ago, and now that he's here, I still see scleroderma patients at National Jewish, and actually occasionally I see quite a few of Dr. Fisher's patients who also have providers at National Jewish. So that's been my background. And honestly, I find patients who have scleroderma to be super challenging. So what I try and do is try and figure out what the problem is and then try and tailor what I say to help people maintain a healthy weight and manage whatever it is that they're dealing with. No one's the same, so there's no one-size-fits-all approach by any means, and I do the best I can to some degree. So I'm glad Dr. Menard Ketcher preceded me because I thought he was great. I was learning stuff. His presentation was short, and then he had lots of time for questions. My presentation is long, so I'd like to take questions during it as we go, if that's okay. So feel free to raise your hand, raise it. Don't raise it, raise it. And then I can respond. I'd really like this to be interactive. And the reason mine's long is that I wanted you to have the information so that you can go back to refer to it. And there are definitely a few places where I won't go over it in minute detail, but I want you to have it for reference. You know, I am familiar with the fact that a lot of patients in general, no matter what they have, they don't really get a lot of time to interact with a dietitian. So you're kind of on your own. So I'd like to be available now during the presentation for questions, and then hopefully my presentation will be some kind of a good reference for you. In terms of an overview, we're going to talk about the nutritional management of the GI issues in scleroderma. So, gastroesophageal reflux disease, or GERD, gastroparesis, which I just learned is rare, and that makes sense with my own personal practice. I don't see it a lot with scleroderma per se. Small intestinal bacterial overgrowth, which apparently is probably the more common manifestation, and constipation. So that's all the GI stuff, and that's probably the bulk of the presentation. We'll talk about what to do with your diet. And then I wanted to mention malnutrition because I think approximately 15 to 20% of patients with scleroderma are malnourished. And I think there's a lot that people don't understand about the malnutrition. And obviously it's related to the GI stuff, the malabsorption and the lack of mixing, like Dr. Menard Ketcher was saying. But there's another component that I think you all need to understand and be aware of. It won't affect everyone with scleroderma, but if it's affecting you, or affecting someone you know who has scleroderma, you should know about it. And then I threw in the anti-inflammatory diet at the end because I spoke at this event 2 years ago, and I got a pile of questions on this. So I tried to make this a little bit more formal. So to start with, in terms of reflux, it is the backflow of stomach contents into the esophagus. It can increase your aspiration risk, as well as it may increase pulmonary complications. So chronic cough, asthma, aspiration pneumonia, and pulmonary fibrosis, which we've heard a little bit about. It occurs when the lower esophageal sphincter muscle weakens or relaxes. That's this sphincter muscle, literally a muscle that's supposed to shut. If it opens or relaxes, then there's an open door for stomach contents to come back up. It also may happen when esophageal clearance is impaired, and we heard about how there's low motility in the whole tract. And it can also happen with gastroparesis, right? Because if your stomach is backed up, it's going to back up the whole rest of your plumbing system. Okay, so we think that specific foods may trigger reflux. So how do foods trigger reflux? Well, the foods may actually weaken your lower esophageal sphincter muscle. It may actually affect the internal working of that muscle. Think of alcohol. I also think of marijuana, actually. But there's actually direct correlation potentially between foods that you eat and what's happening with your musculature. Foods may increase acid production in your stomach. Foods may also increase the pressure in your whole GI tract, particularly your stomach. So think carbonated beverages, right? They want to come back up because of the increased pressure. And some foods may slow your stomach from emptying. So primarily high-fat foods tend to slow stomach emptying. And we also just heard about high-fiber foods can also slow things down. So which foods are those? So in general, the nutritional management is to try and avoid or limit, because you have to live with this, foods that may trigger reflux. So what are those? So alcohol is one of the most potent triggers potentially. Caffeine, including caffeinated and decaffeinated coffee and tea. Why decaf? Because there's still some caffeine in there. Carbonated beverages, like I said, there's gas that wants to come back up. Chocolate is a potent trigger typically. Citrus fruits and juices, so oranges, lemons, limes, grapefruit, pineapple. I would put tomato in here. Technically, botanically, it's a fruit. Fried foods and high-fat foods, so crispy things. Even sautéed things if they're super greasy. And then high-fat foods like salami or like a prime rib, or foods that just naturally have a lot of fat in them. Mint is a trigger. Pepper, like black pepper and other peppers, and spicy foods. So, habanero pepper. I had the unfortunate occasion to eat one of those. Spicy foods, they're probably the most common ones when I talk to patients. Tomatoes and tomato-based foods, including ketchup, including marinara sauce, including your pizza that's made with a tomato sauce. Vinegar and vinegar-based foods, including mustard. Okay, so the disclaimers here are that, okay, you can't, people are like, well, tell me what I can eat. And my cute answer is always, well, just not those things, just everything else. But in general, you do have to learn to live with this. So how do you limit these foods? Well, you can limit the portion size when you eat these foods. You don't have to eat a lot of them at one time. I would argue that eating them earlier in the day may be beneficial because then they'll be out of your system before you're reclining at bed. And then I always say only one insult at a time. So what does that mean? It means don't have your pizza with your soda with a piece of chocolate dessert with coffee afterwards. So you're just combining the effect potentially. And I know Dr. Menard Katcher is big on his probably biggest recommendation is try to avoid eating late at night. So, if you're trying to balance things, try and push things earlier. And then my other big caveat is we don't want you to lose a lot of weight because you're being really strict with a GERD diet. Unless, of course, there's indications for being really strict, and then you have to find a way to eat to maintain a healthy weight and not have the reflux problems. So what questions are there on reflux? Any? I know we've addressed some already. Yeah.
When you have the regurgitation, you talked about the pneumonia and stuff like that.
Mm-hmm.
What exactly, when do you know if you aspirated or not? I know this is not the nutrition question, I should ask Dr.
Yeah.
But when that happens, what is actually happening? I know it's coming up. I'll pop out of bed in the middle of the night. I can't breathe. Am I actually aspirating at that point?
Okay, so Sandy has a good question, and I am going to defer up to the back row here. But Sandy's question, I believe, is what is happening when you're aspirating, and then how do you know? So let me say what maybe I know, and then if I could ping back. Aspiration is the physical breathing in of contents that shouldn't be breathed in. So if you're eating or drinking something, you can aspirate directly that way. It can just go down the wrong tube, right? It can go into your airway instead of your food tube. But if you have reflux, you're lying down, and foods might be coming back up, and then you could potentially breathe it in if it's gotten high enough. Then you've breathed it into your lungs. And I think some people would have that like a I just aspirated, but I believe it can also be asymptomatic. And if you take anything into your lungs, the theory is that if there's bacteria with it, then maybe it's going to transfer that into your lungs, and then it's going to grow there, and you'll get sick. How'd I do?
Great answer.
Okay.
Two aspects. One is it's a very prominent trigger for cough. We will see patients who are aspirating, and that is their cough.
So cough
as I spoke earlier, that cough is not a reliable symptoms for interstitial lung disease, and that it typically, we think a lot about the esophagus. One of the ways that aspiration presents is that the patient is coughing or choking after eating or drinking. The other thing is, I know it impacted at least one of my patients in the room, is sometimes there's a feature of fever, cough, and shortness of breath, and the CAT scan looks abnormal, and there may be a quick early trigger to think that that's the development of interstitial lung disease, but in fact it's aspiration pneumonitis, whereby there's inflammation in the lungs, not because of interstitial lung disease from the scleroderma, but because of the gastric contents that are being swallowed and going down the wrong pipe, so to speak, whereby it injures the lung, leads to inflammation. So we talk to our patients a lot about aspiration precautions, as a result, and it's a reminder that we don't just jump to the conclusion that that new lung process is lung fibrosis. It could just be aspiration injury.
Okay, so are Sandy's symptoms of waking up in the middle of the night, could those possibly be aspiration? Do you think?
So, we gotta, feel compassion for her just on that alone. I don't know. I mean, I always struggle with, trying to diagnose from the podium or from the back row. So I would say any patient who's having, any kind of symptoms that, need to be addressed, it's always hard to do it from this opinion.
Okay,
Sandy, I'm more than happy to talk to you about it.
Yeah. And I guess I actually have a question quickly, Dr. Fisher. Can people get pneumonia from swallowing pathogens, bacteria? Is that where the pneumonia comes from? They swallow the pneumonia bacteria? Our gastric contents are supposed to stay in our gastric gastrointestinal tract. And so as we are ingesting, foreign material, be it food, bacteria, saliva, they should stay out of our lungs. Okay.
So they could be, they could trigger any kind of, immune reaction or inflammatory response because the lungs are looking for a different, environment. And so that switch of swallowing down the wrong pipe, as we say, just irritates the airways.
Okay. So there's irritation of the lungs. Did you want to add something, Dr. Menard-Ketcher?
You can get both what Dr. Fisher was talking about, which is irritation of the lungs, and then if bacteria then kind of grows in that environment, that can lead to a pneumonia. So there is something called aspiration pneumonia. I think overall, though, from the concept of reflux and aspiration, in these cases, our goal is to minimize then the extent of reflux. And what we can't, and then, because our means of doing that are somewhat limited, we need to really be cognizant of when we're more likely to reflux higher. And that's really then we focus on nocturnal reflux when we're horizontal, because then we don't have that ability of the esophagus to kind of clear things as well. And so we really depend on making sure that the stomach, as much as possible, is empty before we become recumbent. And then in some cases, we recommend sleeping almost elevated or at some incline. And that's really the ways we try and minimize that aspiration from reflux events at night.
Yeah, so I'm going to repeat that. He was saying it becomes important to manage reflux, especially when it's going the highest, oftentimes at night when you're reclining, sometimes flat. So the goal is to have your stomach be empty before you're lying down, and in some cases be elevated. And I know Dr. Menard-Ketcher likes to recommend something called a med decline. It's something you can buy that helps you sleep elevated. So, neither do I. Okay, are we good with reflux? I have a few other tips. Those are, you can try during the day to eat small, frequent meals. Again, this may be one of the more important ones. Really try and avoid drinking or eating within 3 hours of bedtime. Try and empty your stomach. Stay upright during the day if you're refluxing during the day. So not a whole lot of this, picking up, tying your shoes, and more of this. So you're upright, because everything we want to move down rather than coming back up. A couple of the doctors that I work with at National Jewish are very strict, so I'm just going to give you their very strict recommendations. That is, some of them recommend limiting your fluids to 6 fluid ounces per hour during the day to avoid a sloshy stomach and backslash, as well as using an adjustable bed. And again, this is slightly different than the Medcline. But if you have an adjustable bed, you can get your head to 30 to 45 degrees, and then the idea is you could consider getting your feet up as well, like you're in a recliner, so that you do not slide, you do not slouch, you don't toss and you don't turn, and actually you're on your back. If you have to sleep on your side, left side is better than right. Okay, so that's it for reflux. Any other questions there? Okay, moving on to gastroparesis. Gastroparesis is slow stomach emptying. Again, we heard from Dr. Menard-Katcher. This is one of the more rare manifestations. I only have one slide on this. So it may cause symptoms of abdominal pain, distension, nausea, vomiting, early satiety, and worsening reflux. How and what you eat may ease those symptoms. So again, small frequent meals, because they're easier to handle, easier to pass. Cut your food into small pieces and chew them well. Soft foods, pureed or semi-liquid or liquid foods may just be easier to digest. Low-fat foods, again, because high fat tends to slow stomach emptying. Low-fiber foods. So this may mean you're doing canned or cooked fruits and vegetables if you can tolerate them versus raw. Processed and refined foods may also be better digested. Again, you have to do it based on your own tolerance. And then foods that are well cooked tend to be partially broken down and easier to digest. So any questions on gastroparesis? This one I think is fairly straightforward. Does anyone have gastroparesis here that they're aware of? Okay, so there's some people. Have you found anything else to be helpful? Not yet. What's that?
Not yet. I'm still working on it.
Right, you're still trying. So these would be the suggestions I would have you try. I realize it may not provide the cure-all, but they may be helpful. Okay, so small intestinal bacterial overgrowth. This happens more commonly. Actually, I kind of like this approach. Show of hands, how many people here think they have or know they have some kind of bacterial overgrowth? Okay, so there's more people, and that reflects what we've just heard. There is a medical definition for this that I found in the literature. I don't know if Dr. Menard-Katcher exactly agrees, but what I found was that it is equal to or greater than about 100,000 colony-forming units, so colonies of bacteria per milliliter, if you grow them, of fluid from your proximal jejunum. That's your think of that as your upper GI tract. Dr. Menard-Katcher said your small bowel is about 21 feet. Did I get that right? That's longer than I knew it was. So you're the first part of that. The first third, I don't know. And typically what you'll have is in that upper GI tract, you'll have a lot of these bacteria, more than normal, and they'll be of a different type. And this is the type that they are. They're anaerobic. They don't like oxygen. They're coliform. That's a classification. They're gram-negative, another classification. It's these bacteria that are typical of the farther bowel that people with bacterial overgrowth tend to have in the upper bowel. Why? Because it's not moving. It's static. So there's less clearance, and they're fermenting stuff that you eat. So in contrast to a healthy individual, I'm not going to go through this in great detail, but there are different kinds of bacteria in the upper GI tract in a healthy individual, and I've listed them there, and they're in smaller numbers. The anaerobic kind are typically found in larger numbers in the farther reaches of the bowel. And these are the kind, like I said, that tend to grow with bacterial overgrowth in the upper parts in people who have the dysmotility. Any questions on that? What it is? There's the reference. Okay, so here are some symptoms that we see when you have more bacteria and different types than you normally should in the upper tract. Distension, pain, bloating, diarrhea, gas. You may see vitamin deficiencies, particularly of the fat-soluble vitamins A, D, and E. Vitamin B12 may also manifest some kind of a low level or deficiency. Why? Because the bacteria use that vitamin as well, so you're in competition. There may be mineral deficiencies, iron, niacin, thiamine. These are the ones that are most often reported in the literature that I found. You may also have fat in your stool due to reduced absorption of fat in the small bowel. And you may have weight loss because you're malabsorbing, essentially. So this is a slide I won't go over in minute detail, but if you want to read more of the specifics, because I like understanding why too, this slide describes why you have some of the symptoms, and it's directly tied to what the bacteria are doing in your small bowel. It's why you may have bloating, distension, pain, gas, diarrhea, some of the vitamin deficiencies, and weight loss. So this is for your reference. Okay, so what should you do about it? Well, it may be worth having a conversation with your GI doctor or whoever's managing this about can we look at what my vitamin levels are? Specifically A, D, and E, and B12, please, if it's not, if they're agreeable. And what about iron, niacin, and thiamine? Can we just get those on my next lab work? Particularly if you have a history of bacterial overgrowth or suspect it. And then it's not unreasonable to consider a multivitamin or single nutrients. Like if you're low in vitamin D, take a high-dose vitamin D. And you can work with your doctor to do that, but replacement is certainly what would be recommended, and then trying to prevent it in the future from happening again. I always recommend third-party certified supplements. These are supplements that an independent third-party certifier has looked at to see if their quality. Do they contain what they say they contain? Do they not contain contaminants? And are they consistent between batches? So I recommend Consumer Lab, NSF, USP. There are others. Those are probably some of the more reputable ones. And then this last recommendation is a little bit out there, but I put it down anyway because, if I were someone who was really struggling with this, I would kind of want to know all my options. But I sometimes recommend water miscible. That means not exactly water soluble, but they're fat soluble vitamins that will mix and be absorbed with water soluble contents. Aquadeck and MVW complete formulation are a couple of vitamins we give out at National Jewish in our cystic fibrosis clinic to patients who have demonstrated and by definition do not absorb fat well in their small bowel. So if you're having some symptoms that might indicate you're having those problems, then I don't think this is unreasonable. These supplements are expensive, so that's the downside there. But if you're not having luck with your current vitamins or minerals in terms of replacement, maybe try something else that might be better absorbed. Okay, so I'm going to just stop and ask if there are any questions so far on this. Yes, let me start here.
If all the nutrients taken is liquids, how does it get absorbed? It goes through so fast. I mean, I have scleroderma, so you can feel it go down my esophagus. But how does it have time to do anything? And it's always diarrhea because all it is
liquid. Okay, that's an interesting question. So she's asking, do liquids get properly absorbed? Because it seems like they just move through you and then you have diarrhea as well. This is a little hard for me to understand without understanding what's causing the diarrhea other than... No, that's okay. I'll actually bounce it back. I know we're not trying to provide advice from the podium, but I would like you to get feedback. So first of all, I would say liquids are absorbed. While it may not seem like it is, you have a long GI tract that has villi on them, and there's a lot of absorptive surface there, even if you have some damage, that you're likely to get some absorption from it. The diarrhea, though, of course, is a whole other issue, and I would want the underlying cause to be determined and then hopefully treated from there. If it happens to be from bacterial overgrowth, I would say you don't want to be drinking just pure sugar. Higher protein, higher fat liquids depending on how much fat you can tolerate, may improve symptoms. You might have to work with the composition of your liquids. Do you have anything to add from the back?
Sure, yeah. The only thing that I would add is that the reassurance that liquid is the normal states by which things are absorbed. The whole goal of the stomach is to make whatever you eat into a liquid that then is better absorbed by the small bowel because contact times increase. So there shouldn't be a lot of concern about liquids themselves. That said, when there's things like bacterial overgrowth that can impair absorption, that can also manifest as diarrhea. And then if the colon is impacted, then you get less liquid resorption and then less solid stool, which can also worsen diarrhea.
Yeah, so that's a good answer. Liquids are the normal state of affairs in terms of how your GI tract is supposed to work and absorb. And then you'll have to look at underlying factors for the diarrhea. And there was another question, yeah.
We get some vitamins from sunlight, correct?
We get vitamin D converted into a good form in our skin from the sunlight. So vitamin D, I would say, is activated by UV radiation. So in theory, yes, sunlight helps you get more vitamin D. However, we know that for whatever reason, even people at our latitude, people in Florida, I've met golfers who 8 hours a day they're in the sun, they don't wear sunscreen, they're burned, and they're vitamin D deficient. So they're different to some degree, but you will get some, but apparently it's maybe not enough, especially if you have malabsorption going on. And we do want you wearing sunscreen, and we prefer you covering up because skin cancer is a real threat.
And I wonder if your skin is impaired, if that would make it not absorb as much. And I don't know.
Right. So is your vitamin D conversion in your skin impaired with scleroderma? I don't know. Any thoughts on that? Don't know. Not sure. Good. There's good rationale behind that. We don't know. We know that people are impaired even without scleroderma. So, yeah. Yep.
Water
Miscible?
Yeah. I know that there's at least B12 and niacin that are available for sublingual.
That are available sublingual?
Is that kind of the same thing? Is a different way of getting it into the system?
Yeah, that's actually a good point. That seems reasonable. If that's not too expensive, I don't know if that's over the counter. That's prescription. Oh, okay. Okay, so there's a suggestion that maybe you could take them sublingually, and those would probably be single nutrients. Yeah, that seems reasonable to me. Okay, so I'm going to go on to some management here. These are general tips. Then I'll move on to the low FODMAP diet, but these are things that I read that I thought might help you. So in order to prevent distension or improve it, don't swallow a lot of air. So avoid carbonation, chewing gum, and big gulps. To improve bloating and gas, try not to eat or ingest a lot of non-absorbable sugars like sorbitol, aspirin, or saccharin. These are sugar substitutes that may not be absorbed and then fermented. I've heard some people just say, I'm just going to try staying off lactose because we know lactose may not be well absorbed, particularly if you have any kind of trouble with your bowel. Fatty foods may exacerbate diarrhea, so you might just try laying off those to see if it helps. Again, these are very general, kind of blunt instruments when it comes to trying to manage the symptoms. I often recommend a higher fat, depending on tolerance with diarrhea, higher protein, lower carb, low fiber diet, because this will essentially prevent you won't be feeding the bacteria, essentially, so you won't get the symptoms that can come from that. This also may help with weight gain if you can tolerate a decent amount of fat, and some people really need to do that. So these are general recommendations. What you may have heard about is the low FODMAP diet. So how many people have heard of this? Okay, so a decent number. This is one of those confusing acronyms that I had to spell out because I forget what it means. It was developed, though, by the Monash University in Melbourne, and it stands for fermentable. That's the F, FODMAP. First one is fermentable, which basically means the bacteria are eating it, then producing gas. And then there's a bunch of the O, D, M, and A is just and, but P is polyols. Those are all short-chain carbohydrates that the bacteria ferment. So FODMAP means fermentable, and then ODMAPs, which are short-chain carbs that the bacteria ferment. So those are specifically the oligosaccharides, fructooligosaccharides, that are also known as fructans or FOS. They are found in wheat, rye, barley, onion, and garlic. Galacto-oligosaccharides, GOS, they're found in legumes. And what I mean by that is like chickpeas, pinto beans, red kidney beans, all your beans that are starchy. And some nuts, some. Disaccharides is the D. These are kind of two sugars. So lactose is the common one, which is found in milk products. Note that some milk products are much lower in lactose than others. So some cheeses are lower in lactose. Cottage cheese. Some yogurts can be lower in lactose as well. So you may be able to have a higher tolerance of those products than straight cow's milk. M stands for monosaccharides. These are single sugars, and particularly it's the free fructose. Fructose is a monosaccharide that is found in a lot of fruits and vegetables. Here are some examples: apples, pears, watermelon, mango, asparagus. And then A is just polyols are sugar polyols that are found added to foods as well as naturally occurring in foods. So maltitol, mannitol, which are found in mushrooms and cauliflower. Sorbitol, which is a sweetener and also found in stone fruits, and xylitol, which is in all the sugar-free gums that the dentist gives out. These are all the short-chain carbs that bacteria can ferment that can cause symptoms for you. And are they the reason that you have symptoms? Probably not. The reason is you have this dysmotility in your bowel. But these carbs, these short-chain carbs, in theory, might not be helping things. They might be making it worse. So we want to try and minimize these. So just to summarize then, or explain this a little bit further, the low FODMAP diet is what is recommended to try if you have small intestinal bacterial overgrowth. Why? Because it is low. It limits the poorly absorbed, osmotically active. That means these short-chain carbs tend to pull water into the GI tract, and they're rapidly fermented short-chain carbs that induce symptoms of abdominal pain, bloating, diarrhea, and or constipation, nausea, and excess wind, as our neighbors down south might say. So does that make sense? Are there any questions here on what the low FODMAP diet is and why it might be helpful? Yes?
One of my questions would be, would you want to try these things not all at once, but see what you personally react to?
So the question is, would you want to try these things more in a stepwise? It sounds like what you're saying is, do you want to do a stepwise elimination approach? The approach that's recommended, honestly, is eliminate everything and then add one back in. Yeah, it's the elimination challenge approach, which tends to be the standard approach for any kind of intolerance, allergy, or potentially intolerance in this case with the bacterial overgrowth. You know, this is a very hard thing to do in practice. So you have to take your situation at whatever works best for you might be starting that way. But in general, in its purest sense, it is better to, and there's more information on this slide that just gives you more information, but it is better to start with an elimination diet of essentially all the FODMAPs for 2 to 6 weeks, where you're only eating the allowed foods that are very low or do not contain FODMAPs. And it's also recommended that you may want to leave time in between your meals to allow for cleansing waves to kind of clear out. And then the idea would be to slowly, one FODMAP group at a time, challenge your diet with these FODMAP groups in increasing amounts. Start with a small amount and then slowly increase. And see if you can subjectively decide which ones are safe and which ones are not, and what amounts are safe and what amounts are not safe. I take all of my recommendations not directly from Monash University in Melbourne, but from a dietitian named Patsy Katsos, who is an IBS sufferer, and she has made this her little niche, and she studies all of the studies and information coming out of Monash University, and she puts it into usable form. So I typically recommend her things, and I have her information in my slides later on. So the goal is to eat the most varied, nutritious diet that you can tolerate and allows you to maintain a healthy weight. We do not want you becoming malnourished on this diet. So I have 2 days worth of meal plans in my slides that honestly I don't really have time for. But I'll go through one day and not the second day. I'll leave that for your reference. But I wanted to show you that it's not impossible because it looks impossible. So a typical breakfast might be something like 1 egg and 2 egg whites scrambled with some sauteed red bell peppers, spinach topped with olives. That sounds good. With a couple slices of Udi's white sandwich bread that is gluten-free. And I should note that the branded foods that are in this presentation and that are in Patsy's materials have been tested by Monash University for FODMAPs. So there are other gluten-free breads, and in theory they should be okay, but they may not have been tested yet. And I will say it's an evolving thing. So Monash University is consistently expanding its list as it does more testing. And it is helpful to try and stay abreast of what's new. I'm telling you what we know now, but it doesn't mean that it excludes other things. So those things with a half a ripe banana and some almond or rice milk, with a snack of hummus, garlic-infused oil, because garlic itself is problematic, but you can cook garlic in oil and then remove the garlic meat and have garlic oil, and that is safe. So there's all these little tips, and you can have that with some veggies. For lunch, you might have some roasted chicken with some brown rice. And by the way, I should also say this, portion sizes can matter. So I've picked the portion sizes carefully per Patsy's recommendations. You can eat that with grilled tomatoes and zucchini as long as it's not a huge reflux trigger, or eat it earlier in the day like we are doing here with lunch. You could have that with a side of berries and snack on a blueberry millet muffin with peanut butter, and that's directly out of Patsy's cookbook, which I have here. I have these to show you. She does have a cookbook It's called Flavor Without FODMAP's cookbook. And she does have IBS free at last. It's for IBS sufferers because we know the low FODMAP diet seems to help about 75% of people with IBS. It may also help people with SIBO because it may help reduce your symptoms. Okay, and then dinner, we've got grilled salmon with some greens, a little bit of cooked quinoa, and some melon or grapes with a snack of almonds and dried cranberries. To me, that looks remarkably normal. So I want you to feel like it takes work, it takes meal planning, it takes reading stuff, but it's doable. So I have another meal plan on here. I'm going to leave that for your reference. Probiotics may be helpful, as Dr. Menard-Ketcher said. They may reduce your functional gut symptoms. They may reduce the bacterial load. What Patsy recommends is that you may try VSL number 3. Starting with 2 caps a day for 4 weeks may help you do a trial to see if it helps. And you may be able to take these long term. In general, they have very few adverse side effects. And here are her references. I also put the Monash University Low FODMAP Diet on here. You can buy the app for your smartphone. And it's consistently updated. So I think that's a really good reference as well. Any other questions on this? Okay, good, because I have to move. So in terms of constipation, this is difficulty emptying bowels, slow transit. We recommend laxatives, not fiber, since fiber can have unintended side effects of bloating and gas, particularly with people who have poor motility. Typically, osmotic laxatives like Miralax are safe. They are safe every day. Docusate sodium is also safe. Stimulant laxatives have also been recommended. They will stimulate contractions in your small bowel. So Senna compounds are what are behind this. And to be safe, you may want to take them every other day or intermittently so your gut doesn't become dependent on it. Any questions on this? So this is the last GI side effect. We've talked about this a little bit already. Okay, in terms of malnutrition, I wanted to make the point that, well, first of all, as a definition, it's undernutrition from active. And when I say active, it means you have an active, probably progressive condition that's associated with systemic inflammation and or potentially you could also have undernutrition from these GI problems. What most people don't realize is if you have a true active, typically more severe progressive condition, you can have this inflammation. And it's supposed to help heal your body, but it has unintended consequences that can lead to malnutrition. So chronic inflammation, we know, causes certain things that aren't necessarily good for your composition, your constitution. So you can have muscle breakdown. You can have muscle loss because of the inflammation. You can have, your body can start to not repair itself and build itself back up as it normally would. It can start to break down. This is all in order to shift your nutrients to deal with the inflammatory response, which is a direct consequence of immune activation. So with an autoimmune disease, if you have a severe ongoing progressive condition, you can have an immune system that causes this inflammation, which causes all these things here, the muscle loss, the fat loss, all to synthesize immune responders. Your metabolic rate can go up, so you're burning more calories than normal. You can have nutrient losses in your urine and potentially in your gut. And I don't mean to say that everyone's going to have this, but you need to know if potentially this is why you might be wasting, because I've seen people who start to waste. And what this means is you need to try and take the meds that will fight the inflammation, but then you need to eat really quite a bit more, as much as tolerated, in order to combat this. So what should you eat? You should eat normally so that you're not skipping meals because you won't be able to get in the calories that you need if you don't. I always try and recommend protein-rich foods. I sat with a woman over lunch, Judy, who was being urged to do the anti-inflammatory thing because of her daughter. And I was still saying you may need to eat protein, particularly as if you become aware of the fact that you have a significant inflammatory response. So good proteins, eggs, dairy if you can tolerate dairy in terms of cottage cheese, milk, or yogurt, full-fat cheese if you need the calories, chicken, fish, or meat, and I'm putting portion sizes on here to encourage you to get reasonable portions. Nuts or seeds, nut butters, cooked legumes. These are beans, again, if you can tolerate them. And try not to fill up on too much water. You can hydrate from a lot of other beverages. Cindy's coming my way. So other recommendations are to add fats and oils to food, And then I provided you a list of all the supplements that I'm aware of that I think are good and reasonable. So I'm not going to go through all of them, but I tried to include a lot of gluten-free, dairy-free, soy-free ones in case you have those intolerances. And so I am out of time. So I think what I'm going to do, honestly, is I'll probably see if there are any last questions. What I put on the anti-inflammatory diet, it comes right out of Dr. Weil's website. He was the one that conceived and originated the anti-inflammatory diet. In general, I recommend what he recommends. So I highlighted things that I thought were specifically important to him, to his diet, as well as things I would agree with are anti-inflammatory. And I'll leave it at that and take some last questions so we can keep moving. Any other questions? Yes.
What about genetically modified stuff? Do you think any of this stuff is affecting our inflammatory stuff and our reactions to food in our diet?
So the question is, do GMOs cause inflammation? Is that the question? Yeah. Certainly that hasn't been proven. It's speculative. Do I think it does? No, I don't. What I do think might be problematic with GMOs, my only beef with GMOs is that they're patented and they're controlled by large multinational corporations, and there's a lot of spin-offs to that I think are problematic. That's a political thing, though, so that's not a nutrition thing. Nutritionally, I don't think they're harmful, and I recommend them, particularly if it's too expensive to buy organic everything. Organic is non-GMO. Certified organic means non-GMO, but it comes at a price. So I hope that was helpful. And I hope this was helpful, and I'm sorry I didn't quite get through all of it. But I hope, like I said, I hope this was helpful.